All right, welcome everyone who are joining us today on a lovely Tuesday, or maybe not too lovely if it's very hot over there. It's going to be very hot here in New York City, where I'm joining this webinar from. Um, but thank you for joining us today, and it's nice to see some familiar names coming in who also joined our session on July 8th on improving extreme heat risk communication to protect pregnant women and children. Um, I think we have a decent amount of people who've joined us, Lynn. So Lynn will be supporting me today. And I want to invite everyone to first introduce themselves in chat and, share where you're joining from, what part of the world. And also just want to let people know that you are welcome to ask questions anytime in the Q&A box. You can ask it in the chat, but that tends to be harder for us. So if you can go to the Q&A function of Zoom and ask your questions there, we will encourage our panelists to answer them throughout the webinar. And if not, if we don't get to it, then we'll get to it at the Q&A as well. But before we really jump into it, let's warm up with a quick poll, with a quick quiz question. Lynn, I think I can launch it. So I'm going to do that. And I'm going to launch it. So you guys should be able to see a quick quiz to warm up about cooling down. So the question is, using an electric fan to cool the body is only effective up until what temperature? All right, I'm seeing answers come in. This is great. I'm also curious if our panelists know. I'm sure they know. They know. Great. Wow, we have like a pretty even spread. Lynn, what did you pick?
I'm actually not able to pick as a co-host, but I do already know the answer.
Okay, yeah. Well, don't. Okay, good, good. Well, in that case, let's not give it away. We'll give it another 10 seconds.
We have about 60 participants, so let me know when you want it
Yeah.
to be shown the results.
Okay, I think now's good. All right, if everyone can see, we kind of see an even division almost, but I do like that a lot of people pick 35 degrees Celsius, 95 degrees Fahrenheit, because that has been the advisory that most governments and WHO have given until recently. I want to invite, I don't know, any of the panelists, would you like to come in and say what the updated guidance is now? Maybe Dr. Tess?
Sure, happy to. So we were just chatting about this before, and it's been now pretty publicized that the updated guidance is up to 40 degrees Celsius. So 104 Fahrenheit, you can cool with a fan. And obviously, this, depends on humidity, depends on other factors, but the updated guidance is up to 40 degrees Celsius.
Awesome. Thank you. It's always good to have the expert come in and verify that. So thank you for that. And this update is happening in large part thanks to ongoing research by heat experts like Dr. Tess and others who've joined the call, who are always looking to refine our understanding of our physiological and physical factors that contribute to heat stress in our bodies. So now I'll introduce myself. So for those who I haven't had the pleasure to meet yet, my name is Swati Manchkanti, and I support UNICEF's climate and health work. And I always try to start my mornings with the question, what can I learn today? And I'm joined by my colleague, Lynn Greer, who supports all things comms and advocacy on our team. And she's also supporting me today. So I'm thankful for that. And this is why I'm excited to host these types of webinars, because it gives me a chance to bring together experts from all around the world who are leading the way on addressing climate change's impact on children. But before we jump into it, when it comes to protecting children from the impacts of extreme heat, which we covered in our last webinar, and Lynn is going to help link to the chat, the recording and the presentation, we co-developed the Beat the Heat framework as a guidance with other experts for frontline workers and health professionals who are seeking to communicate the risks of extreme heat and treat heat-related illnesses effectively, particularly in pregnant women and children, who in the past have generally been overlooked. And so that includes, disseminating message to help the general population as well as caregivers be aware, that's the B, of what causes heat stress and how they can protect themselves from it. So there's a few different sets of messages that you can go through afterwards. The next step would be to know how to easily identify symptoms of various heat-related illnesses and then also the unique symptoms that manifest in pregnant women and children. So that's the E. And then the third is to help frontline workers know the steps for acting immediately to cool the body and help the pregnant women and children rehydrate and recover as well. And the T would actually be for transport to a healthcare facility if the symptoms are deemed severe. And it's important for frontline workers and health professionals to know, what a severe symptom also looks like. You can find all of this information in our technical note, which will be linked in the chat shortly. And you'll be able to also find these slides on the event page for this particular webinar in a few days, so they can check out the other resource links as well. So I shared all that to basically introduce the theme for today's conversation, which is how country governments and researchers are incorporating elements of this framework into their work on adapting health facilities and services to better identify, manage, and treat heat-related illnesses, including in pregnant women and children. So today we'll be hearing case studies from the government of Bangladesh and India on the important work being led by the ministries of health there to prepare for treating heat-related illnesses ahead of each heat season and during, followed by a presentation on critical heat and health capacity building initiatives that are being implemented on the front lines in low and middle income countries. And we'll close with some exciting new research and results coming out that can help us further improve how we treat heat going forward, particularly in women. Our first presentation, apologies for not updating the name here, but our first presentation was supposed to be done by Dr. Afreen Mahmood and Dr. Priscilla Wobil. Unfortunately, Dr. Afreen Mahmood isn't able to join us today as she's feeling under the weather. So we're very grateful that actually Dr. Rahman was able to step in on her behalf. Dr. Arafat Rahman is a public health professional with over 14 years of experience in Bangladesh's health system. He holds a Master's of Science in Healthcare Administration from Nagoya University in Japan and a Master's in Public Health and Epidemiology from NIPSOM. He is currently serving as a Deputy Program Manager in the Planning and Research Unit of the Directorate General of Health Services under the Ministry of Health and Family Welfare. His contributions span health systems reform, maternal, newborn, child, and adolescent healthcare, family planning programs, maternal death surveillance and response, quality assurance, and coordination of health services for forcibly displaced Myanmar nationals. Dr. Priscilla Wobil is a pediatrician, and public health specialist with over 20 years of experience in clinical care, maternal, newborn, and child health system strengthening, and program leadership in Ghana and Bangladesh. She currently works as a health specialist at UNICEF Bangladesh, where she leads the environmental health, climate change, and public health emergency preparedness and response system. Over to you, Dr. Rahman and Dr. Wobil.
Thank you very much, Swati. I would want to say that the presentation outline would look basically at understanding the impact of climate change and heat in Bangladesh. And then we would walk you through the process for development of the National Heat-Related Illness Guideline, and then also share some key components of the guideline, and then where we are at on capacity building, health facility data, and reporting in the GHIN system, and also risk communication approaches using Beat the Heat as you described. And then we would end with the next steps. So with that, I would want to say we've worked closely with the DGHS and the Ministry of Health on this work, and we are happy to share the work that has been done so far. So I will hand over to Dr. Arafat Rahman to continue with the presentation. Over to you.
Thank you, Priscilla. Thank you, Swati, for inviting us to be part of this webinar. And I'm very happy and definitely excited to share our experience in addressing the growing impact of heat waves, particularly as the burden of extreme heat continues to rise due to climate changes. So if we look at the slide, so that's focusing on the climate changes risk in Bangladesh. As one of the most climate vulnerable countries in the world, Bangladesh faces compounded risk. The Children's Climate Risk Index, CCRI, for Bangladesh stands at 7.6, placing us in extremely high risk category. So this includes as a shock risk score of 9.1 and child vulnerability score of 95.1. All of highlights climate risk. The map in the right side shows how every district in Bangladesh is affected by multiple climate hazards, ranging from extreme heat, droughts, cold waves, and landslides to cyclones and flash floods. If you see the districts highlighted in yellow, those are the areas for extreme hot days. The extreme hot days are even increasing along with the climate changes. Next slide, please. So, understanding the impact of climate changes and heat in Bangladesh, actually, this chart shows the sharp rise in the extreme heat days in Bangladesh between 2010 and 2025. The acceleration since 2020 mirrors global climate trends. Increasing trends in extreme heat days, more than 36 degrees in Bangladesh from 2010 to 2025, particularly in pre-monsoon and monsoon seasons due to combined heat and high humidity. And in May 2024, we have seen that schools are closed nationwide due to that extreme heat wave, impacting about 33 million of children. Cities like Dhaka hit over 40 degrees Celsius on multiple days, with peak temperatures reaching as the high as 43.8 degrees Celsius. Next slide, please. So, with the continued understanding the impact of climate change and heat in Bangladesh, we have seen May 2023 to May 2024, Bangladesh experienced 76 extreme heat days compared to just 19 expected historically, which is fourfold increase due to the climate changes. In June to August 2024, about 119 million people, which is about 2/3 of the population, experienced more than 30 days of the extreme heat. May 2024 to May 2025, we estimated show that Bangladesh suffered about 24 days of extreme heat. Children, pregnant women, the elderly, and outdoor workers are especially vulnerable to heat-related illness. So rising heat-related illness is placing additional burden on already stretched health facilities, particularly during prolonged heat waves. As Bangladesh is prone to multi-hazard, this threatens the achievement for the maternal neonatal child health targets. Next slide. So recognizing these alarming trends, Directorate General of Health Services, with the support from UNICEF, developed a national guidelines on heat-related illness. Beat the heat messages that's what he mentioned, and the materials are also developed and included in the guideline. And we have just seen the Beat the Heat refers to the BO, where easily identify, act immediately, and take to the health facilities. Next slide, please. So the process for development of the National Health Guidelines, we started the planning process in December 2023. And with that, in January 2024, we conducted a national country situation analysis, followed by the formation of the Technical Advisory Committee. Stakeholder workshops were held in March and April, where key experts and partners came together to develop these guidelines. During this time, we also created culturally tailored the heat communication materials in Bengali and rolled out training session for the medical staffs nationwide. In May 2024, the Ministry of Health and Family Welfare and GHHIN officially launched its first ever national guideline on the heat-related illness, alongside a national public awareness campaign and frontline health workers training. Next slide, please. So we are currently integrating the data collection and reporting through the GHHIN. The city corporation have started working on a national heat action plan, reflecting a strong commitment in both national and local levels. The key components of the guidelines that has three parts. The first part explains the scale and exposure pathways of the health impacts from the heat stress. And part B outlines the preparedness and response actions covering the health facility readiness and risk communication and community engagement preparedness plan. And the final part that includes the components describe the clinical management of health-related illness, including management of the health-related illness of children, pregnant women, and adolescents. Yeah. Next slide, please.
You just have 2 minutes, Dr. Rahman.
So I'll be very quick. So with the progress, we are as July 2024, Bangladesh has been focusing on the capacity building, improved health data and reporting, and risk communication using these national guidelines. Next slide, please. Yeah, on the capacity development, national level training for trainers was conducted. 32 trainers received training throughout the country. And from all the 8 divisions of the country, over 1,300 health care providers have been trained. Next slide, please. Regarding the health facility data reporting in the GHHIN, here is the monthly trend of the patients admitted for the heat stroke. If we look at the trend, April to June is the peak season of the heat stroke due to the high monthly temperatures, and 2024 having the highest number of the patients overall. So overall, the cases in 2024 the highest, and the implementation of the guideline would have contributed to the reduced heat stroke cases seen in 2025. Next slide, please. Yeah, so risk communication using Beat the Heat messages for the Beat the Heat campaign. More than 70,000 people reached through the community engagement, and almost 5.1 million reached through the social media. Yeah, next slide, please. Community volunteers are helping the pregnant mothers cope with the heat stress. So if you look at the picture of community volunteers are helping pregnant mothers cope with the heat-related stress in Bangladesh. So in this picture, a community health volunteer named Akhi is helping patients named Shilpi, 23 years old, pregnant women to cope with the stress, and who has attended for the antenatal care checkup. So these volunteers provide the targeted health education, disseminating Beat the Heat messages, supporting the routine antenatal care, and more attention during the heat season, and acting as the trusted community links. Next slide, please. I'm very close to the end. With this, we have a holistic approach is required, and integrated heat response in health sector through the strengthening risk communication and community engagement. Washing healthcare facilities is very important. Green health infrastructure is also very significant, required. Clean energy such as health facility solarization, quality data for decision making, and available and adequate medicine, logistics, and human resource but quality care is also very important. Integration in maternal and child health services and strong leadership at national, subnational levels with the relevant policies and guidelines are also very important for the to cope up with this heat-related illness. With that, so this is all from our side. Thank you, everyone, for your very patient hearing and very valuable time. Thank you.
Thank
Over
you
to
so
you,
much.
Sophie.
Thank you so much, Dr. Rahman and Dr. Wobil. It's really great to see. I think your story is demonstrating the importance of setting the foundation correctly for adaptation with like a strong policy framework. And I also appreciate the data that you've shared on patients admitted with heat strokes. And I think as all countries kind of improve their data collection process, we'll be able to actually see exactly, how risk communication efforts are helping mitigate future heat stroke cases from happening in the first place. So thank you very much for that. Now we'll hear from the government of India on what they're doing to improve diagnosis and treatment as well. So Dr. Narottam Sharma works as an additional director for hospital administration in the Department of Medical Health and Family Welfare in the government of Rajasthan. He holds a degree in community medicine and has more than 30 years of working experience in the public health sector with the government of Rajasthan. He is playing a key role in the delivery of medical and health services in the state of Rajasthan with a focus on reproductive, maternal, newborn, child health, healthcare, and climate change. He was awarded the State Merit Certificate for extraordinary work during COVID-19 pandemic from the Honorable Chief Minister of Rajasthan himself. He'll be accompanied by Dr. Anil Agarwal, who has more than 25 years of experience in clinical medicine and public health. He's currently working as a health specialist with UNICEF in the field office of Rajasthan, and he has been instrumental in shaping many digital and process innovations in the state and other countries like Sierra Leone during the Ebola outbreak. Over to you, Dr. Sharma and Dr. Agarwal.
Thank you, Swati, and good evening, good morning, and namaste to everyone. Myself and Dr. Narottam will share the experience from the state of Rajasthan. Can we go to the next slide, please, Swati? So this is the overview of our presentation. We would like to share how SDG and climate change are linked, which most of us know about Rajasthan a bit. What are the contributing factors and major diseases and their impact? How did we go ahead in development of action plan, capacity building, various innovations, and then some case studies. Next slide, please. So we all know that how climate change is directly through SDG 13 as well as, next slide, please, and 3. But we are talking more about the SDG 3 as well as 13 here in the state of Rajasthan. How other sectors are also involved, we'll talk during the presentation. Next slide, please. Rajasthan, if we look at, is the largest state of India. It occupies around more than 10% of the geographical area of such a vast country, India. It's the 8th most populous state of India. 87 million is its population. If we look at the pregnancy load, 1.85 million pregnancies and 1.7 million live births every year. Half the state is, you can see in the picture, it's diverse in terms of its geographical location. On the western part, we have huge desert area. On the southern part, we have hilly terrain. And on the eastern part, we have different challenges in terms of the forest and the dacoits, and everything used to happen earlier, but now it's better, but still deprivations are huge. We occupy around 10% of geographical area, but only 1% of water. It's a very water scarce state in the country. We have extreme temperature and weather conditions. If you look at summer, we go up to 50-degree temperature in sometimes. And winter, it reaches to 0 degree in many of the districts. So water freezes here. So it's extreme weather condition. Next slide, please, Swati. In this state we are working, and you can see how things are changing even in the state of Rajasthan. Earlier we used to talk about the maternal newborn survival as the top cause of death, but now undernutrition, which is also directly impacted by the climate change and the air pollution and other issues are emerging. Next slide, please. And this we all know, who have all joined, that how climate change is affecting every part, every dimension. And in Rajasthan, we are working in all dimensions, be it the severe weather condition, air pollution, the vector-borne diseases, allergies. We are trying to work in every area of the climate change, which some of it Dr. Narottam will be presenting today. Next slide, please. If you look at the state in last year, how the heat wave have, and the good thing was that last year we had very good prediction, and so were this year. We were ready in the month of March for the month of May, when we saw the complete state was having severe heat waves. The entire state was red, you can see. That's how it was. And likewise was this year. So I'll hand it over to Dr. Narottam, that how he worked on developing the plan, and then how we put those health facilities in shape. So over to you, Dr. Narottam.
Thank you, Dr. Anil, and namaskar to all of you. I am very thankful to Government of Rajasthan, UNICEF, and the Global Heat Health Information Network for giving us the opportunity to showcase Rajasthan's efforts in heat wave management to global audience. In line with NPCCHH guidelines issued by NCDC Delhi, Government of India, we brought together experts from various sectors: health, urban planning, agriculture, and environment, to form a multi-sectoral task force. This played an instrumental role to strengthen policy coherence, interdepartmental collaboration, and community engagement to all levels. Next slide, please. The evidence-based district heat action plan were prepared across all 42 districts of Rajasthan. Action-oriented, documented, shaped through an inclusive process. District nodal officers are appointed from state headquarters, who visited respective district for monitoring ground level preparation and reporting from every health institute. Monitoring and periodic review meetings were conducted from state level. Next slide, please. We have strengthened health facility readiness through physical assessments on different parameters and mock drills. Established a clinical protocol and over 3,500 heat stroke rooms, along with more than 9,000 beds, 9,000 beds, cooling equipments, safe drinking waters, and training of staff. Ensured engagement of different stakeholders. Next slide. Simultaneously, we worked to strengthen the referral system and did situational analysis using digital technology. Over 1,600 ambulances were equipped with tarpaulin assisted cooling with oscillation tacho technique and essential supply. Protocols for rapid cooling and patients with heat related illness using tacho technique have been submitted and demonstrated down to health workforce. Next slide. We did the comprehensive data management through a dynamic and interactive dashboard that helped us to monitor and make decisions right down to facility level. For example, you all can see that 3,626 health facilities reported daily, 10 suspected patients reported on a given day, over 0.89 million patients have visited emergency OPD overall. 385 confirmed cases were treated so far during this heat wave. A total of 9,484 beds were reserved for heat stroke cases. We utilized digital technology to strengthen our preparedness. and they mitigate the impact of extreme heat on our people. The e-evidence forms the foundation of our continuous cycle of planning, reviewing, revising, replanning our strategy and actions. Next slide, please. We developed and issued advisory for administrators, managers, and consultants. Guidelines were issued for working hours and rest time during day to reduce exposure. Clinical protocol for heat stroke cases. Module for grassroots workers in local language. Advisory issued and awareness activities conducted for general public and vulnerable groups. Disseminated system specific training modules for record maintenance and reporting. Next slide. These are some awareness videos. If time permits, we can see, or else we will also share with you. Next slide, please. Because of interdepartmental convergence through task force, you can see that it's not only limited to health facility or referral. Community level interventions are also implemented. For example, green shades at traffic intersection to protect vulnerable populations like commuters and traffic police. Next slide. Also, we introduced a cost-effective and innovative digital knowledge assessment and capacity building approach for the health workforce. Over a period of 70 days, 10 quizzes were conducted, receiving more than 0.17 million responses with an impressive 82% correct response rate. Next slide.
You just have 1 minute left, Dr. Sharma.
Yes, please, ma'am. Yes. These are the some claims that heat illness related activities like IC display at public places, awareness generation, motivational activity during World Health Day, essential supplied at NREGA sites and for laborers, and capacity building and reviewing during monthly sector meeting. Madam, next slide. All efforts successfully implemented the plan on field and 0 death reported in state. The results speak themselves. Our coordinated and data-informed approach has shown measurable impact, and we remain committed to refining the scaling this model. Last slide, please, ma'am. We believe that with continued collaboration with UNICEF, we can build climate resilient health system that protect every life. We thank you for this opportunity to share our work. Thank you, ma'am.
Thank you, sir. Thank you, Dr. Sharma. Thank you, Dr. Anil, for sharing this work that your team is leading in Rajasthan and for sharing lessons for how improving treatment practices is also helping improving surveillance and vice versa. It was great to see, I think, a separate record of the number of the percentage of pediatric cases that were admitted, because this will really help us, I think, in the future get better records on exactly where and how children are being affected by heat in the state. So thank you so much for leading this work. We'll just jump right into our next presentation with Dr. Cecilia Sorensen, who is the director of the Global Consortium on Climate and Health Education at Columbia University and Associate Professor of Emergency Medicine at Columbia Irving Medical Center and Associate Professor of Environmental Health Sciences at Mailman School of Public Health, Columbia. Dr. Sorensen serves on the steering committee for the National Academy of Medicine Action Collaborative for Decarbonization of the U.S. Health Sector and is a member of the Strategic Advisory Group on Climate Change and Environmental Determinants of Health for the Pan American Health Organization, or PAHO. She is also the co-editor of the textbook Climate Change and Human Health from Science to Practice. Over to you, Dr. Cecilia.
Thank you so much, Swasti, and really a pleasure and an honor to be here talking about this really, really important issue. My goal today is to share with you some work we've been doing around pathways and programs to improve heat-related health outcomes, focusing on our Climate Care Champions program in India. Next slide, please. So a little background on the Global Consortium on Climate and Health Education. This is an initiative which is based at the Mailman School of Public Health at Columbia University. It was initiated at the 2015 COP21 Paris Climate Accords and was launched in early 2017. Our mission is really to ensure that all health professionals throughout the world have the knowledge and skills to identify, prevent, reduce, and respond to the health impacts of climate change thereby reducing health disparities and improving the quality of health and well-being. At our core, we have a consortium of over 400 health professional training institutions representing over 70 countries, and we are currently reaching approximately 300,000 health professional students from backgrounds of nursing, medicine, public health, pharmacy, and so on and so forth. We also do a lot of work across many different pillars, including technical consultancy, professional capacity building, and community-focused solutions, which I'm going to talk about today. Next slide, please. So as a background, the Climate Care Champions program was co-developed between the Global Consortium on Climate and Health Education and SWASTI, which is a community-based organization in India, and was founded really to address this critical knowledge gap among frontline and community health workers in heat-vulnerable regions. India's frontline health workers, which include auxiliary nurse midwives, community health officers, and ASHA workers, really are this vital link between communities and the health system. We know that they are very well positioned to raise awareness, identify symptoms, and implement preventative strategies for climate-related health issues. And therefore, strengthening their role through education and practice is really key to building community resilience to climate-related risks, including extreme heat. So the Climate Care Champions program is a train the trainer cascading program that really teaches frontline health workers to identify, prevent, and respond to the health impacts of heat. And we really focus this around maternal and child populations. So initially, we piloted this program in 2024 using SWASTI's frontline community health workers, and then we scaled this in partnership with the Ministry of Health of Andhra Pradesh in early 2025. Next slide, please. So the curriculum for this training, it's really a 2-day in-person intensive training where we are working directly with the trainers of trainers to lay out foundational knowledge and understanding of the health impacts of heat. We start with the basics of heat exposure. We're working in areas where it always is hot. Geographically, it is incredibly hot there. So how can we articulate when heat becomes dangerous, including hot nights, consecutive days of extreme heat, talking about what is a heat wave, what are heat wave definitions, talking about heat adaptation, and really trying to understand when does heat become dangerous, because it is always hot. Can you go back one slide, Swasti? Thank you. Then we talk about the basics of heat-related illness. Why does heat illness occur? And particularly, how does it manifest? When you look at sort of the clinical symptoms of heat-related illness, it can masquerade as many different types of diseases, as well as issues related to pregnancy and common complications related to childhood. So we have to really focus here on identifying those symptoms that are consistent with heat-related illness. And then looking at how we rate the severity of this. Is this mild heat illness, moderate, or severe? And so through our 2-day workshop, we really do a lot of scenario-based training and working through different cases to help community health workers really understand how to grade the severity of heat-related illness. And this is something that we have learned through our program that we need to kind of reinforce and develop again and again and again, the right models to help frontline community health workers understand. The last really core pillar of our training is training community health workers to provide preventative guidance to families, pregnant women, and children who they are working with. These are very vulnerable areas. There are not a lot of resources present among communities. And so how can communities really work with the resources they have to reduce their risk? Next slide, please. So all of this training is really based around the UNICEF Beat the Heat framework, which I had the honor of working with the UNICEF team to co-develop. And what we really need to understand here is that being aware of heat-related illness is just so crucial. And again, especially in these very hot regions, we need to think that heat-related illness is in the differential. We need to intervene early, and we need to act in the right way, depending on the severity of symptoms, which can include taking vulnerable and symptomatic patients to health facilities. Next slide, please. So for those of you who aren't familiar with the framework, you can see here that we have created in this technical guide many different frameworks that can be used to help properly triage critical patients, as well as provide steps that can be taken in the field in order to prevent escalation of heat-related illness. Next slide, please. So here's some pictures of phase 2 of our training, but what we learned following the implementation of phase 1 where we initially focused on training 26 master trainers who then went back and trained an additional 400 community health workers, is that really this scenario-based, case-based training is so crucial to really equip frontline community health workers with the skills and the language that is required in order to communicate risk to patients. We ran a survey pre and post this training, received a lot of feedback from this initial cohort of trainers, and then improved the program for the second year, which I'll talk about next. Before I get there, I wanted to add that we developed many different tools that could be used by frontline community health workers in the field, which are all based around the Beat the Heat framework, translated into 6 different languages to enable frontline community health workers to have sort of this job tool to use in the field. Next slide, please. So phase 2 of this program was launched in January 2025 in collaboration with the Ministry of Health of the District of Anantapuramu in Andhra Pradesh. And we know that Andhra Pradesh is the second most climate vulnerable state in India, really prone to many different hydrometeorological events, including extreme heat events, droughts, floods, and so on and so forth. And we were really grateful to work with this district because they were able to bring to the training representatives from their 91 unique primary health clinics. And they sent senior representatives to this Train the Trainer program, which included nurses as well as physicians. And that's really key here because we were able to really integrate this program directly with the existing network of the provision of healthcare in the district. Again, this was a 2-day workshop, very case-based, very interactive, and we can go to the next slide here. The other great thing about connecting directly with these primary health clinics is we were able to share with them resources that come from the Beat the Heat framework and the technical note that was created by UNICEF, including these evidence-based flow charts on how to manage the treatment of heat-related illness in different populations. So from a medical perspective, we have a lot of information about best practices on how to treat adults when it comes to heat-related illness and heat stroke, but there is a paucity of evidence in terms of what the best way is to manage severe heat-related illness in children as well as in pregnant women. And so what's really, I think, unique about this technical note is that we were able to work with experts, look at the best evidence, and put together a framework that is informed by best practices to help primary health facilities really triage and manage properly the treatment of heat-related illness, especially in pregnant women and children. And so please feel free to look at the technical note. We have flow charts here that can be easily lifted and applied to really any setting from a low resource setting to a high resource setting. There's definitely strategies that can be deployed in low resource settings as well as high resource settings. So we encourage you to look there. Next slide, please. So we really had this incredible impact. So by training 91 health professionals representing each of these primary health districts, they were then able to go back to their primary health clinics and train an additional 2,200 frontline community health workers. And this was incredible because the impact was that over 4.5 million people were actually reached, because that's the number of people who were really served by these primary health clinics. And what was so unique about this model is that we were really able to harmonize messaging in terms of what communities were getting from community health workers in the field. And they were getting the same messages when they went to hospitals and primary health clinics from their providers. And so this harmonized approach in this district, we think, was really helpful in terms of hopefully being able to impact health outcomes. Next slide, please. So this is just a little bit of an anecdote from one of our trainers, and he provided this feedback based on the training that he had received through the Climate Care Champions program. So this is told from the perspective of the community health worker. On March 21st, he encountered Mr. R, who is a 28-year-old male who was experiencing vomiting and fatigue after returning home from work. Using his training from the Climate Care Champions program, he immediately took the patient's vital signs and found that his temperature was elevated at a dangerous level, potentially compatible with heat stroke. He also found that the patient's blood pressure had dropped, probably due to underlying dehydration because he had been working all day. And he was taken immediately into a cool area. Water was applied, and the patient was placed under a fan. So what happened next is that the patient's condition did not stabilize. And therefore, he was immediately transported to the nearest primary health clinic for definitive treatment. And so what's so important about this example is that the patient symptoms were identified immediately. Treatment was provided in the field. And when the patient did not improve, the right decision was made to transport the patient immediately to a primary care clinic. So it sounds straightforward, but really making sure that frontline community health workers are doing what actually is pretty complicated medical decision-making is more difficult than it appears at surface level. I would just say that when we're working with frontline community health workers, their background training is not that of obviously a fully qualified, fully fledged health professional. And so really being able to work through scenarios with community health workers is so important. So they know all these critical decision-making points and are able to make the right decisions in that scenario. Now, what happened after this case is that it became very public. A lot of people in the community came out and saw this gentleman who was suffering from heat stroke. And after that, our Climate Care Champions Program trainee did a teaching for the whole community about heat stroke and heat related illness. And so it became this really teachable moment for the community. And what was so incredible in my mind is that this frontline community health worker was really armed with the best evidence. I mean, we're talking about, the best evidence you can get from the, any published academic resource from UNICEF. And this worker is actually giving that evidence directly in the field. Next slide, please. And then I'll wrap up.
Okay, perfect. I was just about to say, over to you.
Thanks. So as part of SWASTI and GCCHE's work, a heat action plan was developed by the district, and the Climate Care Champions program is integrated into this heat action plan. And again, part of this is really ensuring that all health workers in the district have the same roadmap, have the same blueprint in terms of how we talk about the spectrum of heat-related illness, of the critical steps that need to be taken. And so there's constant reinforcement. And I think that's so critical to preventing heat-related illness that all health professionals, all facilities are on the same page with this. So we really look forward to seeing the implementation of this heat action plan. Next slide, please. So a couple of takeaways from the trainings which we've done so far is that really contextualizing heat-related illness in communities is so important. And we were grateful to be working with SWASTI because they work so closely with communities, and developing those training scenarios were very realistic, right? They were able to sort of know exactly what community health workers were encountering and make the training very realistic and very practical for frontline community health workers. Working with the district, we were able to sort of understand a bit more about the current tracking system in the medical record related to heat-related illness. And the district is working to improve that, which I think is really important for us to be able to understand the impact of the programs which we do. We find that co-investment by government really is ensuring sustainability and scalability, and we look forward to scaling this program in other districts as well as other states and countries. One of our takeaways was—
Sorry, Dr. Sorensen, I might have to cut you off.
Fine,
Here.
thank you.
No, I apologize. But the slide will be shared with everybody after this presentation, of course. And I appreciate that you raised the issue of the medical records. Oh, this was actually your last slide. Yeah, medical records and the proper coding that needs to be used, because that was a question that was raised in chat as well. And if we have a few minutes, it'd be great to answer that in Q&A. And now it is my pleasure to introduce our last but not least speaker, Dr. Tess Wiskell, who is a practicing emergency medicine physician at Beth Israel Deaconess Medical Center in Boston and faculty at Harvard Medical School. She received her medical degree from the University of Chicago, completed emergency medical residency at Brown University, and underwent specialized training with Climate and Health Fellowship and Master of Public Health at Harvard University. She's currently a Harvard Global Health Institute Burke Fellow, investigating health impacts of occupational heat stress. Over to you, Dr. Wiskell.
Thank you so much, Swati, and thank you so much to all the speakers so far who have shared really amazing examples of initiatives that are being taken. We're going to take a slightly different perspective for this talk and talk a little bit more about a research study we're working on that we're partnering with civil society organizations in India, where we're working with women who are working in the informal sector in India to really determine what it is the heat that they are experiencing and what this means for their lives and livelihoods, and how this can help guide community heat adaptation and treatment strategies. So next slide. So first I want to talk a little bit about why we're doing this work and what some of the existing ascertainment challenges are in heat and health. And these are a few images from our partner organization of where women are working and living. And we know workers are exposed to extreme heat, with over 2.4 billion workers exposed to excessive heat every year. But what does this mean for the lives and livelihoods of the working poor, who are often working in the informal sector without protections? And what temperatures are they really experiencing in their homes and workplaces? Just from these images, you can see there's a heterogeneity of experiences that may not be captured by our weather station readings and outdoor satellites. And then what does this really mean for their health when they're exposed to this long term and over time? So that's what started this program and research study. Next slide, please. We called Community Heat Adaptation and Treatment Strategies in South Asia. And this is an image showing how we have set up this study, where you can see what we did was put microenvironmental sensors, so these small sensors in homes and workplaces of women, so we can see what heat they're really experiencing in their homes, what are the temperatures and humidity, and then have them wear these physiologic monitors to see what is really happening to their physiology, measuring their heart rate, movement patterns, and sleep patterns. We gave all the women smartphone devices to be able to track these different measurements. And then we have regular check-ins with community workers and additional assessments to track other parts of health, everything from blood pressure and core temperature to more qualitative assessments. And what I want to share today are some of our preliminary results from this work over the last year. Next slide, please. So these are preliminary results from our initial cohort of about 100 home-based workers that are working in everything from garment stitching to kite making, from around Ahmedabad in India, where we've placed these environmental monitors in homes and measured temperature and humidity, monitored physiology over the course of the year, and done additional perceptual surveys asking what is their thermal comfort, what are sleep patterns, what are their wages like, and additional assessments of serum analyses, as well as other quantitative physiologic measurements. So our initial results from this study are on the next slide. So this slide shows the results of what the air temperatures are in homes from these sensors we placed compared to what they are from the outdoor weather station. So the red represents the temperatures in home from the indoor microsensors, and blue is from the outdoor weather stations. And this graph is showing over the course of one day, and you can start to see a pattern emerging. So you can see a pattern here where at night, the homes of these workers are really not cooling down. The red bars stay elevated higher than the temperature of the outdoor weather stations. And although the homes are slightly cooler during the daytime, if someone is leaving for work, they're experiencing these hot temperatures outside and then coming home where the temperatures are not cooling at all. And you can see this over the course of a day. And you can see that for really over 2/3 of this month-long period that we assessed this for, air temperatures exceeded the upper limits of comfortable temperature. So we know these women are living and working in elevated temperatures in their homes. So what happens then as monsoons come in? So next slide, please. So this graph is showing the temperatures for the months after the hottest period as the air temperature is starting to cool, but the humidity is rising as monsoons come in. So you can see the black line here are the air temperature as measured from the indoor microsensors. And you can see the blue line is the absolute humidity that is increasing. And the red line is showing us the heat index, or really the feels-like temperature, where you bring together the air temperature and the humidity. And you can see how this remains persistently elevated in the months after the hottest season. So there's really no respite from the heat. And you can see the difference here from the red line that is solid compared to the dotted lines, which are from the weather stations, and how it's significantly higher in the homes of these women compared to what it is outside and what we're getting monitored from the outdoor weather stations. So what does this mean for physiology? What does this mean for the actual health of these women? What does this mean for their livelihoods? So we talked about how we were also using physiologic monitoring. Next slide, please. So what you can start to see here on this is looking at the heart rates measured by these physiologic monitors, the average heart rate compared to the heat index in this exposure response curve. And you can see here the persistently elevated heart rates as the heat index is elevated. And this is over the course of the year. And what this is starting to show us is just how we are seeing the signs of heat strain and stress over time with significantly elevated and sustained elevated heart rates over time with elevated heat indices. And this model was adjusted for different seasonal effects, physical characteristics of the participants, physical activity, and we're still seeing these elevated heart rates. And so what does this mean for people with different underlying medical conditions? So we also did different assessments of underlying medical conditions, including anemia. So next slide, please. And here you can see this exposure response curve separated into participants with and without anemia. And you can see that there's significantly more elevated heart rates in those who are anemic compared to those who aren't anemic. And this is starting to help give us insights into maybe what protections we can offer for people living and working in the heat. For instance, maybe treatment of anemia would help reduce some of the chronic heat strain, thinking about nutritional diets and malnutrition and vitamin deficiencies. This is one way to start thinking. More to come from this project. And next slide, please. And we talked not just about health, but also well-being and livelihoods. And when participants reported their wages, we collected this. And you can see here the daily wages compared to what the afternoon air temperatures are, and just how there is decrease in daily wages reported compared to the air temperature outside. So not only is heat impacting the health and heart rate and strain to these women, it's also impacting their livelihoods and decreasing their wages. We have to think about what this means for long-term exposures to heat and what this means for women working and living in the heat. All right, next slide. So in summary, we can see from this initial research that the conditions experienced in homes and workplaces are different from our outdoor weather station readings, and that workers are experiencing prolonged and heterogeneous heat stress, resulting in this physiologic strain. We see that underlying chronic conditions like anemia are exacerbating this heat strain, and that it's having far-reaching impacts, not just on our health, but also on livelihoods with decreasing wages in the heat. And hopefully what this will allow us to do is use this model to evaluate different adaptations and think about what we can do as far as treatment strategies to prevent harm for women that are living long-term and exposed to this heat long-term. I know we're running out of time, so I will stop there and allow some time for questions. Next slide. Here's my contact information. For anybody interested, please reach out.
Thank you so much, Dr. Tess. That was succinct, but also so insightful. And also thanks to you and your team for, helping the global community just kind of go one step further in filling this knowledge gap that we have, especially when it comes to the difference between outdoor heat and indoor heat and how different bodies and different sexes feel that differently as well. So this was really, really great. And we look forward to the next round of results that come out. We actually just have a minute left, so you finished just in time for us to say goodbye, unfortunately. We want to once again thank all our presenters, Dr. Rahman, Dr. Wobil, Dr. Sharma, lots of doctors, lots of knowledgeable people here. Dr. Sharma, Dr. Agarwal, Dr. Sorensen, and Dr. Wiskel for all of their great knowledge that they've shared here today. There was a great question in the Q&A box about a possible toolkit that can be used to take a lot of this messaging forward. We will consult with our panelists and make sure there's at least one toolkit linked in the follow-up email that we'll send sometime in the next week or so. Thank you all for joining us, and please keep your eye out for the last webinar of our series, which will take place near the second half of August. Thank you all again. Stay safe, stay hydrated,
Thank you.
and stay cool. Thank you.